Optimizing sexual well-being and intimacy after a prostate cancer diagnosis. Did I get the title right? Perfect. Reanne Booker is an oncology and palliative care nurse practitioner with over 20 years experience in cancer care. She works with the hematology-oncology team at the Tom Baker Cancer Center right here in Calgary. Her clinical and research interests include integrating palliative care in oncology, sexuality and cancer, medical cannabis and cancer, and virtual cancer care. So a wide range of expertise. 9 years ago, then President Steve Bellway introduced our guest speaker. Since then, her presentation that she did that night's been viewed over 94,000 times. So it's with great pleasure that I welcome back to Prostate Calgary our very own YouTube channel rock star, Reanne Booker.
Wonderful. Well, thank you so much, Brad, and thank you so much for the invite to come back, and thanks to everyone who's here today and also joining online, and thank you, Rhett, for your tech expertise. We couldn't do this without you. I think that this is just absolutely wonderful that this topic has been viewed as many times as it has been. I think it's a testament to how important this topic really is for people, and not just in the prostate cancer world. So we at the Tom Baker Cancer Center, for a period of time, a short period of time, we had a sexual health clinic that was running right at the cancer center for about 3 years or so, and then the funding ran out, unfortunately. So we don't have the sexual health cancer program anymore at the cancer center. But through feedback from all of you, and for anybody viewing online, if this is a topic that's of importance to you and you'd like to see a sexual health clinic at the cancer center, please provide that feedback. We're about to open a brand new cancer center, the Arthur Child Comprehensive Cancer Center in Calgary, in October, and wouldn't it be great if we had a sexual health clinic there? I think that would be wonderful. I don't really have any relevant conflicts of interest to disclose. I don't receive any funding or anything like that from any industry or medical supply companies. I have received some funding for my PhD studies through nonprofit organizations and governmental organizations to help with my research. Again, as Brad mentioned, I can't, in the context of this presentation, be giving overt medical information or advice. I always advise people or encourage people to speak with their physicians and their treatment team before they're making changes to their treatment plan. I'm happy if people want to email me afterwards if you have specific questions or things, then I can help you with information, but I can't give medical advice. So hopefully I'll give you lots of good information and things to ask your care team. So today, really what I want to talk about is what is sexuality, what is the impact of prostate cancer and the treatment on sexuality and intimacy, and then talk about some strategies to really help optimize sexual health and well-being. So I think, we think about sexuality, sometimes we think about sexual function and sexual intercourse specifically, but sexuality really is a broader concept. It really encompasses a lot more than just sexual function. So it's all about being human, our gender identities and roles, sexual orientation, pleasure, intimacy, reproduction, all those different things, and really can be experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, behaviors. So many different things influence sexuality. Oftentimes we do focus on sexual function, and I will talk about that a lot tonight because that's certainly something that's very, can be potentially adversely impacted by prostate cancer. But sexuality is a broader concept, so just to keep that in the back of your head as well. And when I first started working in cancer care many, many years ago at the Cross Cancer Institute in Edmonton, I worked in the GU medical oncology group. So I worked with prostate cancer patients and testicular cancer patients, and we always asked patients about sexual function and sexual concerns. And then I started working in other areas, different tumor groups, and hematology in particular, blood cancers, and I started asking those patients as well about these concerns, and found that it's almost as much, if not more, concern for patients in other types of cancer groups as well. And so when we had our sexual health clinic, we did have people with prostate cancer for sure, and some of the other GU or gynae cancers and breast cancer. But we also had patients with really any different type of cancer, even people who are not receiving active treatment, disease-directed treatment. Just that diagnosis of cancer can really impact sexuality and body image and all kinds of different things. And again, this was a diagram I came up with when I first started working in sexual health and cancer, just to really emphasize how complex this concept is. So someone comes into a cancer diagnosis with an array of different factors that might influence sexual health and sexuality to begin with. So things like age, religion, culture, background, if there's a partner or a spouse, and what those experiences have been like on their own before the cancer diagnosis. Then the cancer, its treatment, symptoms related to the cancer, side effects from the treatment, the psychologic impact too, so things like anxiety, depression, and some of that might precede the cancer diagnosis or might be made worse by the cancer diagnosis. And then really any other medical conditions that might influence sexual function as well. So we think about neurovascular function, so nervous, the nerves, vascular is blood, endocrine, hormones function. So anything that impacts those systems can impact sexual function as well. And of course the brain being one of the most important sex organs as well. So there's so many different things that can influence sexuality and sexual function. And then across the illness trajectory. So, a lot of people, in a study we did a number of years ago, we had some patients who we interviewed and said, how is sexuality important to you, and what would you like to know about sexuality in the context of your cancer diagnosis? And I remember one patient saying, maybe not at the time of diagnosis, you have cancer, how's your sex life? Those two things maybe don't go hand in hand. But he said, I would have liked to know up front what impact my treatment might have on sexual function. Is it safe to have sexual intercourse? Is it safe to engage in different activities, and what might not be safe? And then fertility preservation as well. If that's important to somebody, it's important to have those discussions before treatment starts. Sharing the information about the sexual side effects of treatment. So again, in prostate cancer, those side effects can be very profound with respect to sexual function. Similarly, in breast cancer and other types of cancer, there can be really profound sexual side effects associated with treatment. And then during treatment, of course, as I mentioned, talking about safe sex practices, things to maybe avoid in terms of making sure that the activity is safe for the partner and the person engaging. And then recovery and survivorship is when we saw most of the patients come to our sexual health clinic. So the main disease-directed treatment had finished, and the person was now trying to get back to their normal or new normal, and they wanted to come and see us because at that point they realized, hey, there's some changes here that are really not very good for me and my partner. And again, another time where people maybe not be thinking as much about sexual function and sexuality is advanced disease and at end of life. But I will tell you again, in all my experience in palliative care, it may not be that somebody's really desiring sexual intercourse, but they really desire that intimacy. So physical, emotional intimacy, being with their partner, that can be really important even in the context of advanced disease and when somebody is dying. There's so many different ways that treatment can impact sexual function and sexuality. So we know one of the most common concerns we saw in our clinic, our sexual health clinic, was difficulties with erectile function and difficulty with interest or desire. And those were very common changes that we saw, irrespective really of the type of cancer or the type of treatment. It was something that was very common. And so we can see, I'll get into the specifics here in a few minutes, but you can see sexual function concerns can be very common. And then of course also psychosocial concerns. So concerns related to body image, self-esteem, depression, anxiety, fear of cancer recurrence, fear of cancer progression, and then difficulties with the relationship and navigating those changes that can come. So with prostate cancer treatment specifically, there's an array of different treatment approaches, and sometimes we'll do what's called active surveillance or observation or watchful waiting, where there's not any chemotherapy, radiation, or surgery. We're just kind of watching that PSA and maybe watching some scans to see what happens. And then the other modality is a treatment. So surgery is pretty common, radiation therapy, hormone therapy, or more likely, or more aptly named, I guess, anti-hormone therapy. Systemic therapy, so things like chemotherapy or immunotherapy. Sometimes there's a combination of a variety of these different treatments. Very often that's what we'll do. And then supportive care, that would be maybe we're not focusing so much on disease-directed treatment, but relieving symptoms and improving quality of life. And the types of side effects really vary depending on the type of treatment and the individual patient themselves. So if they have other medical conditions, how old they were, other medications they might be taking. Some people experience very mild side effects, and other people might have really severe or profound side effects. So surgery, we talk about things like prostatectomy. That's where we talk about removal of the seminal vesicles and the prostate gland itself. And so it's important there to remember that then no more fluid can come in from the testicles or prostate. So there's no fluid buildup in the urethra. There's not that sense of fullness or inevitability prior to ejaculation. And there's no ejaculate or no semen that comes out. Prostatectomy can also lead to penile shortening and other challenges with erectile function. There can be damage to the nerve bundles that control the blood flow to the penis. There can be damage to the nerves themselves and sensation of the penile tissues. And there can also be changes in pelvic floor function. So when we talk about ways to help sexual function, pelvic floor physiotherapy is one thing that might help some people. Nerve-sparing surgery, really important. Even with nerve-sparing surgery, sometimes we still do see, and quite often we still do see erectile challenges. For some people that can improve up to 2 years or more after surgery, so don't be discouraged if there's loss of function immediately. It can return. And then other treatments that we look at, orchiectomy, so that would be removal of the testicles, one or both, and that causes a loss of testosterone. So again, testosterone can feed prostate cancer cells. So if we take the testicles away, we can reduce the source of testosterone. But taking away that testosterone can cause decreased interest in sexual activity, can cause erectile problems. And then other procedures, transurethral resection of the prostate or TURP. There can be damage to the little valve at the top of the urethra that can cause retrograde ejaculation, where there's ejaculation then that goes into the bladder. So nothing comes out the urethra, it goes the other way into the bladder. And there can also be erectile challenges as well with transurethral resection of the prostate. Anything else to say about this? Again, just to emphasize that it can take up to 2 years to regain erectile function after surgery. And important factors in predicting post-surgery erectile function, so age, depending on how function was prior to the surgery, the quality of the erections, and then any other medical conditions as well can influence post-op success and erectile function. So again, that's the TURP procedure, just showing that there's a device that goes in and you can cause some damage to the top of the urethra that can cause retrograde ejaculation. And then radiation is one of our mainstays of treatment for prostate cancer. So we have external beam. So that's where this first diagram, I guess, at the top, where somebody's laying on a table, and usually it's very quick, the radiation procedure. It's only usually typically a few minutes, and there's a radiation beam that comes externally. So that's external beam. And then brachytherapy is where there are radioactive seeds that are implanted near the prostate, the surgery bed, and that causes a release of a radioactive treatment right at the prostate site. And sometimes there can be a combination of different types of radiation therapy used. And so side effects after radiation, we can see erectile changes up to 70% of the time. And that can sometimes get worse for the first few years, up to 2 years or so post-radiation. The rates after brachytherapy alone seem to be a bit better than the external beam. So it's a little more specific. It's more targeted. The brachytherapy is right at the site versus external beam coming from the outside in. We can see decreased volume or absence of semen 50% of the time or more. There can sometimes be discomfort during ejaculation. So not really what anyone wants, but there can be some pain with ejaculation. So that often can be because there's an irritation of either the urethra or the epididymis because of radiation. That usually gets better for most people. Sometimes we can see some blood in the semen as well. That usually resolves the further someone gets out from radiation. Again, there can be decreased interest or desire. There can be decreased intensity of orgasm and decreased satisfaction with sex. And again, it's the same with women too. So if you think about if the experience is painful, well, then that can influence desire, because nobody really wants to be involved in doing something that's going to hurt. And so then even if it's not at the forefront of your mind, at the back of your mind, if your mind is thinking, well, this last time I did this really hurt or was painful or there was blood, then your mind can really influence the next experience. So that piece is really important as well. The damage from radiation, we think it's probably the blood vessels that we're damaging from the radiation, so causing some scarring potentially to the arteries in particular, and also some damage to the nerves. Radiation can speed up hardening, narrowing, or even blockage of the arteries in the pelvic area. Again, I mentioned there can be that post-radiation epididymitis where there's painful ejaculation, but better techniques with radiation, more specific and targeted techniques, are leading to better outcomes in terms of sexual and pelvic health. And so I think in time, and we are getting better at all the cancer centers, I would say, especially at the Tom Baker Cancer Center in Calgary, there's a real desire to make sure that all the modalities of treatment, so surgery, radiation, and all those things, that we're really minimizing harms and really optimizing outcomes. And that's true, I would say, of all of our cancer treatments, is that we're really trying to minimize side effects and harms and really optimize the outcomes in terms of controlling the cancer or eradicating it where possible. Hormone therapy, again, as I mentioned, it's more anti-hormone therapy. So because we know that prostate cancer cells can grow in the presence of testosterone, when we block the presence of testosterone or block the production of testosterone, we can reduce the chance that those cancer cells will grow. And so we can either decrease the production by the testes, or we can block the androgens in the body at the receptor. And so there's different ways that we do this. But again, if we're blocking the potential growth because of testosterone at the site of the prostate cancer cells, it's not only specific to blocking at the site of the prostate cancer cells, we're blocking the effects of testosterone pretty much everywhere. And that can lead to decreased interest in sexual function, can lead to erectile problems. Almost 90% after androgen deprivation therapy, we'll see problems with erections, difficulties with erections. There can be hot flashes, weight gain, fatigue, tiredness. There can be breast growth as well. There can be changes in penile length and testicular size as well. It's not traditional chemotherapy in the sense that it will cause hair loss and vomiting and nausea and things like that, but it is potentially going to cause an array of other side effects that can be bothersome as well. And immunotherapy is a little newer, and we use it in different types of cancers for sure, and certainly in prostate cancer, we're using it more frequently. And so this is quite a busy slide, but just showing a bunch of the different cells involved in prostate cancer, and we can target some of these cells and target some of these pathways and spare the healthy cells by harnessing the power of the body's own immune system. And sometimes we'll use these new treatments in combination with traditional treatments, and we can really have good effects that way while minimizing the side effects as well. I will say that right now, the impact on sexual function of immunotherapy agents, even in other types of cancers, we don't really know yet because they're quite new. But this is being studied, and something that is definitely on the radar of sexual health specialists in cancer care, which are growing in number too, which is great news. So this is something coming, and we'll keep an eye on for sure in terms of the impact on sexual health and sexual function. So again, as I mentioned, and I think in our clinic we saw this very frequently, was changes in desire, interest in sex, and sometimes, once we figured out what the issue was, if it was painful intercourse, if it was relationship issues, if it was erectile issues for women, if it was painful intercourse or vaginal dryness or vaginal changes, if we targeted some of those specific individual problems, we saw that desire and interest in sex actually got better. Changes in desire are very common with any of the types of treatments, but it's also very common as we age. Our changing hormones can influence desire and libido as we get older. And it used to be, so this diagram on the left is the sexual response cycle that's been well described for many years, described by Masters and Johnson many years ago. And there's I think it's on Netflix, a show about Masters and Johnson and sexual health and all these things. I haven't watched it yet, but I should. But there used to be this notion that we needed spontaneous desire before the sexual health kind of sexual response cycle began. So you needed desire, spontaneous desire, then that was followed by excitement, and then there could be excitement, arousal, and then orgasm, and then a plateau. now we know that you don't always need that spontaneous desire, that you can have a satisfying sexual encounter and hit all those other kind of points in the sexual response cycle, even if that spontaneous desire isn't there. And so, this notion that somebody needs to have that desire first, I think deters some people because they might feel like, I'm not in the mood, I haven't had any sexual thoughts, I'm not interested. But if they actually get involved in some physical intimacy, maybe it's massage, maybe it's a cuddle or a bath or dancing, then that desire might come after. So it doesn't have to always be there to begin with. And again, as we age, that spontaneous desire notion is not always there anyway. So I think just keeping that in mind, because again, as we get older and different treatments and different medications can influence desire, if that spontaneous desire, that innate sexual hunger just isn't there, it doesn't mean that you can't go on and have satisfying sexual experiences and kind of, tick all the other boxes, so to speak. So again, I think it didn't really matter the type of diagnosis or treatment in our sexual health clinic. Changes in erectile function were probably the most common concern that we saw with the men that came to our clinic. And it was often difficulty achieving erections, difficulty maintaining erections, difficulty with insufficient firmness for penetrative intercourse. And you need about a 30% firmer erection for anal intercourse compared to vaginal intercourse, so that can be important as well. And then loss of spontaneous erections, so not waking up with morning erections, not having middle of the night erections and those kinds of things, very common. Changes in erectile function are very normal and can happen as we age. So more than 50% of men over the age of 40 have some degree of erectile difficulties, even in the absence of a cancer diagnosis or other medical concern. And we know also that there's lots of other medical conditions and medications that can influence erectile function. So again, anything that impacts nerve damage or nerve function, so nerve damage, diabetes, things like that can cause neuropathy. Changes to the blood vessels, changes in hormones, psychological impact of a cancer diagnosis especially, and very often it's all of the above. After a cancer diagnosis, we can see all those different changes. Again, changes with ejaculation, we didn't see a lot in our clinic, but did come up from time to time. So there can be delayed or premature ejaculation, again, especially if there's nerve damage that happens. There can be pain with ejaculation, or dysejaculation is the medical term. Again, that can sometimes be caused by irritation of the urethra from radiation or irritation of the epididymis, and that usually would go away over time. So, the further someone is out from surgery or radiation, that would tend to get better. We did see some patients, not necessarily with prostate cancer, but other types of cancers, with an aching in the testicles when there was ejaculation. There can definitely be less production of semen. So sometimes completely no semen at all, or anejaculation or dry ejaculation. And again, especially if there's been surgery where the prostate's been removed, if there's been radiation to the prostate area, and even after hormone therapy for prostate cancer, we can see changes in the amount of ejaculate that comes out at time of orgasm. And then the other concern, I think I mentioned already, was the retrograde ejaculation that can happen after transurethral resection of the prostate. And then there can also be leakage of urine at the time of ejaculation. So that's called climacturia. And that can be upwards of 90% plus in people after treatment for prostate cancer. So very common. This is a very common concern. And it varies in terms of how often it happens and the amount of urine that leaks. Sometimes it can be a little bit of urine, and sometimes it can be a lot of urine. And I'll talk about ways to kind of deal with that in a few minutes. And then changes in orgasm. Again, so some people have said that there can be decreased, and most commonly we'd see decreased intensity of orgasm. Sometimes we see increased intensity of orgasm. Sometimes we see complete lack of orgasm altogether. There can be painful orgasm. Again, sometimes that's tied to painful ejaculation for men. That would be called dysorgasmia. We didn't see that all the time, and in our clinic, we didn't see it all that often. If we could tackle some of the other concerns, sometimes we would be very successful at reducing painful orgasm. I think it's also really important to emphasize that there can still be orgasm even if there is not erection or ejaculation. So that's really important after treatment for prostate cancer, is You don't need an erection to have an orgasm. You don't need ejaculation to have orgasm. And that's something I think that a lot of men in our clinic were not aware of. So that was good news for some, for sure, is just hearing about that. And then fertility preservation, again, I think this depends on so many different factors. This could be a talk in and of itself. Ideally, we like to talk about fertility preservation before cancer treatment starts. That's not always realistic, depending on the type of cancer and the urgency. But for men, the mainstay really still is sperm cryopreservation, so sperm banking. And that's the best, kind of most well-studied method of preserving fertility. And we know that treatment for prostate cancer can temporarily or permanently impact fertility. So again, we like to have those discussions before treatment starts. There can be some costs associated. So it's usually about $400 for the first year of storage and about $200 or so per year thereafter for storing sperm samples. There are other types of fertility preservation strategies, but most of those are still considered experimental. So really it is sperm banking that's the mainstay of fertility preservation. And again, as I mentioned, body image can be very, very significantly impacted for men after prostate cancer surgery. So we know, not just surgery, radiation, androgen deprivation therapy. There can be things like penile shortening. There can be changes in penile girth after surgery, hormone treatment, radiation. The mechanisms by which that happens are still quite unclear, but there's suspicion that the cavernosal hypoxia, so lack of oxygen to the penile tissues, causes a profibrotic, or almost like an increase in scar tissue, and increased collagen deposition, and that changes the smooth muscle, and that can cause penile shortening. And then again, after androgen deprivation therapy, we can see things like testicular shrinkage, breast enlargement, weight gain. Some men can have weight loss with certain types of treatment. There can be hot flashes and things, and all of these things can impact body image. Richard Wassersug is a professor at UBC. I think he's spoken for Prostate before. Yes, he's wonderful. And he's done a lot of work in this area about body image especially, and has done written some really thought-provoking articles on how masculinity is defined and just the changes in hormones and things and how that can really impact body image and self-image and all of that. So I think, there's videos, I'm sure, on the Prostate website or Prostate Cancer Canada as well has had him speak to. So he's quite interesting to hear and has lots of wonderful things to share. And then again, relationship changes. I think, this can be very challenging if it's either a new or long-term relationship alike. So sometimes, you think about, well, what if somebody is just starting dating? When did they disclose their cancer history? How do you bring that up? But similarly, if somebody's been in a long-term relationship or a long-term marriage, and maybe they didn't talk about sex before, and this is a new concern and a big concern, how do you bring it up? And that was something in our clinic that I really appreciated. We had psychologists that worked in the clinic, so we tackled things really from the biopsychosocial perspective. And for couples that were not used to talking about sexual health, or if sometimes there were very heavy religious influences where they're just not comfortable talking about sexuality and sexual function, our psychologists worked with the couple to be able to have open communication about concerns. So again, if it's been a long-term relationship, and then all of a sudden the sexual aspect of that relationship changes, that can be quite devastating for the couple. And similarly, if it's a single person trying to date, and I remember reading on one website, it was a young woman, she was in her 30s, and she said cancer was her douchebag filter. And she said, this is part of who she was, just the same as having, brown eyes or any other feature of who she was. And she said some people understand it and some don't. But when she was dating, she disclosed it quite early on, and she said it was her douchebag filter, and how somebody reacted told her a lot about if she wanted to be with that person or not. So it can be challenging in relationships for sure, and we know that there's not been a lot of research in this area. So again, we're very lucky in Calgary. We've got Dr. John Robinson, who unfortunately now is retired, but Dr. Lauren Walker and some other psychologists who have looked at the impact of cancer diagnoses, and specifically prostate cancer, on the relationship aspect and partners. Partners specifically, again, I feel caregivers and partners we don't do enough for. I wish that we had a whole care pathway just for partners and caregivers alone, and I know that Prostate does great work for partners. I think it can be such a huge, profound life change for partners and caregivers that we really don't do enough at the cancer center level to support caregivers and partners. And I'm hoping that we'll change that with our new cancer center. And there is research that shows that a patient's well-being can often be directly tied to the caregiver's well-being. So even survival outcomes can be improved if the caregiver's well-being is attended to, then the patient does better in terms of survival in some types of cancers. So that just shows us how important it is to really focus on caregiver well-being. But in terms of sexual health and sexual relationships, partners might feel worried about causing pain or discomfort during sexual activity. They might feel themselves unwanted or unattractive or even rejected due to the decreased sexual activity. They might feel that there's been such a change in their role from being a partner to now they're being a caregiver, and changing hats like that can be quite difficult. So trying to be caregiving and focusing on all those caregiving tasks, and then now trying to be the partner, especially in a sexual relationship, that can be quite a 180 for sure. And then some partners will pull back a bit and just worried about potentially losing their loved one. They might pull back as a means of protecting their feelings and things. I remember early in my cancer work history, it was a couple, the woman had breast cancer. And of course, in breast cancer, we do a lot of manipulation with hormones and things too. And same thing. So her interest in sexual activity decreased dramatically. And as I was talking about that, just giving them information, you could see his eyes light up. And he had thought that she didn't love him anymore and that she wasn't interested anymore. But nobody had really given them that information. And what a difference it would have been upfront to have that information, so that she didn't feel on the spot about it, but that he could recognize that it wasn't personal, that it was the treatment that was causing these changes in her interest in sexual activity. So I think, again, at the Cancer Center, we have work to do. I wish that we would be a lot more forthcoming to the extent that people are comfortable receiving the information, but just be available and make sure that that door is open for people. And what else to say about that? Yeah, I just think that we need to be doing a lot more for partners, and then recognizing too, partners might also have their own sexual health concerns. So again, as we're all getting older, there can be vulvovaginal changes associated with menopause that can make sexual function and sexual activity quite painful. There can be other medical conditions as well. So I think that the partner health is really significant in this, in the relationship and the sexual health considerations of the men with prostate cancer. Sexual and gender minorities, another area that we really don't spend very much time on as we should be doing. There's not a lot of research in this area, but approximately 3 to 12% plus of the U.S. population identifies as LGBTQ. We know that LGBTQ patients have lower rates of early detection, lower access to screening for cancer, and there's lack of resources that are tailored to their needs. I think it's really important. So we always talk about, and this survey was done by the American Society of Clinical Oncology, or published, in the American Society of Clinical Oncology journal. The authors surveyed a bunch of oncologists across the U.S., and the feedback was, well, I treat everyone the same. So, a lot of times the oncologists would say, no, I don't do anything differently for LGBTQ patients. I treat everyone the same. But we want to, in healthcare, strive for equity, not equality. And so I always think about it, well, if I had a patient who was blind, I wouldn't just say, well, I'm giving you the same handout I give everyone else, and I'm treating you the same, because that would not meet their needs because they couldn't see it. So we have to think about their needs and what is unique and what's not being met. And certainly this is one area where there's a lot more research and supports that need to be done. We do have in Calgary, again, some specialists and some family medicine practitioners as well that are very interested in LGBTQ health. We don't have enough of them, of course. But again, it's, I think, really important that we make sure that LGBTQ patients feel safe in our cancer centers to share their concerns, and that we do our best to address them. So there are specific challenges, I would say, for gay, bisexual, and men who have sex with men. And so we know that the prostate can be a site of sexual pleasure during receptive anal intercourse. And the loss of ejaculate can be very important and profound for men. There can be rectal irritation or pain, so that can make anal intercourse very painful and difficult. There can be, as I mentioned earlier, there can be inadequate penile rigidity, so insufficient firmness of erections for anal intercourse. There can be changes in the sexual roles from top to bottom that can be quite significant and distressing. The absence of erection can be very worrisome and difficult for men in the gay, bisexual, and men who have sex with men population. Again, change in penile size, girth, length. And some of the changes, I would say, are the same after prostate cancer for heterosexual men, but there are some that are more specific, I think, that we don't always do a good job about educating men up front and their partners and supporting their needs. And a lot of our patient education materials are very heterosexist, so they're developed with a heterosexual couple in mind and a male-female relationship in mind. But there are some really good websites and brochures and things like that available online. And again, this is something I think not a lot of people necessarily think about, but prostate cancer in transgender women. So transgender women, so that's somebody who was born biologically as a male but has transitioned to female. Typically, they still keep their prostate. So even if they've had gender confirming surgery, such as removing the testicles or even having vaginoplasty, they most often will still keep the prostate. Now, they're often using feminizing hormones, so estrogens and things like that. So tracking the PSA is not useful because the impact of estrogens on the PSA renders it not as effective as a test. So that's really important. And then just thinking about how difficult it could be for someone who identifies as female to then have a male-associated cancer and have to go into the cancer center for treatment for prostate cancer. If they're identifying as a female, that can be very difficult. So again, I think I'm hopeful that our new cancer center will have a lot more training and sensitivities in these areas, but again, awareness of what to screen for and watch for sure. And again, the risk of prostate cancer in this population, because they're on estrogens or feminizing hormones, the risk is thought to be low, but it's probably not zero. So, we have to be aware of concerns for sure. And then again, as I mentioned, thinking about particularly advanced disease or end-of-life care, or when somebody is in hospital. And oh gosh, now it was probably a good 5 or 6 years ago as well. I was asked to go speak at one of the hospices in Calgary, because their staff had encountered a couple in hospice, and they said this is the first time that this has happened, where one of the staff had walked in on the couple, and they said, we don't know what to do about this. Like, should we have some socks on the doors, or should we have a sign, or what should we do? And I thought, well, this is great that they're having the conversation, but if you think about it, in hospital, it's not conducive to even physical intimacy. It doesn't have to be sexual intercourse, but cuddling in bed. The beds are single beds. They're not double beds. They're hard to cuddle in, and there is no privacy. We're terrible about just barging in, or sometimes we'll do the simultaneous knock on the door and barge in at the same time. But there can be other concerns as well when people are in hospital or when they're feeling quite unwell. So things like pain, shortness of breath, fatigue, weakness, nausea, vomiting, dry mouth, diarrhea, cognitive changes. Again, the environment, especially in hospital, not very inviting. The oxygen, the tubings, and different things like that. Lack of privacy. So, I've talked to so many people in my palliative care role where they've said, geez, it would sure be nice if we could have just a double bed even here for the last, remaining days or weeks, where they could just snuggle in bed together. And, that doesn't seem like that would be such a hard thing to do. It just, again, it's talking to the right people and getting these changes implemented. Again, I don't think it'd be the end of the world to do this. It wouldn't be terribly expensive, but it would make a difference for somebody for sure, to be able to snuggle and just be there. The physical intimacy is one part and the emotional intimacy another part for sure. But I think as I move now into the interventions and what we do, I'll emphasize that sexual intercourse is not the be-all, end-all, that, it's the physical intimacy, the other ways to express sexual function and sexuality that can be really important. So again, in our clinic, we really took a biopsychosocial approach, recognizing that sometimes there were physical factors that impacted sexuality and sexual function. There were psychological factors, relationship, interpersonal issues, and all of it worked together. So we were lucky to have the psychologists and myself handle kind of the medical stuff. We had consultant urologists and gynecologists we could bring in if we needed. So we tackled it really from this kind of very comprehensive approach, dealing with mind, body, and everything else, because that's really sexual function and sexuality really relies on all those different aspects. And so again, thinking about interventions, psychology counseling, I always think that that's a good idea, and to the extent it's available. And again, we're lucky at the Cancer Center, we do have counselors and psychologists available for people. In rural and remote areas, that's not as easy for sure, but now we have virtual cancer care that should be able to help with some of these things. So getting resources out to people in rural and remote areas so they don't always have to come into the Cancer Center. Partner and caregiver role, helping with support and assistance for the partner and the caregiver so they can stay in that partner role and not have to focus on being the caregiver all the time. So if that means getting in services, especially towards advanced disease and end of life, if it's getting in home care, different supports to be able to allow the partner to just be a partner and not have to be the caregiver all the time. There's different other devices and specific things I'll get into in a second here. Obviously, managing cancer and treatment-related symptoms. So if pain is an issue that's precluding sexual activity, well, let's manage the pain and get the pain under control. And the same with nausea or shortness of breath. Penile rehabilitation, so there's some research that's been done at a number of different cancer centers in the States and elsewhere, showing that if we kind of jump on the penile rehabilitation early on, especially after surgery and in the context of even radiation and things, that we might be able to prevent erectile issues down the road. So some thought even that just even having erections, even if they're not leading to sexual activity, can help with getting blood flow to the penis, improving oxygenation of the tissues, that will prevent problems down the road. The research has been hit and miss, so some studies really suggest that penile rehabilitation is wonderful and others haven't been as compelling. But that's something always that I recommend people talk to their urologist and their treatment team, ideally before treatment starts, if possible. And then pelvic floor physiotherapy, and this is not a regular physiotherapist who just dabbles in the pelvic floor physio area, but somebody who's a pelvic floor specialist. They can really help with different pelvic floor issues that can sometimes be contributing to erectile problems, pelvic pain, and different issues like that. And I'm a strong believer in referring to, different disciplines as needed. So again, as I mentioned, we were able to involve psychologists right in our clinic and then referring to urologists and hormone doctors as needed. Communication is really key. And again, this is something that maybe can be taken for granted, but not everyone feels comfortable talking about sexual health issues or relationship issues. It can be very putting yourself in a vulnerable position, especially if this is something that's not been discussed ever in the relationship. Sometimes patients wait for their partner to initiate sexual activity, and the partners then wait for the patient, and then nobody initiates or no one talks about it. And so, just being as open as you can be. And again, this is where I really felt, grateful to have the benefit of our psychologists to be able to help people with communication issues, because it can be very difficult if it's not something that's ever been done before. So this was Dr. Lauren Walker it's tiny, but you can access these slides. I'm happy to email anybody the slides as well if you'd like to have them yourself. But even just, discussions around sexual activity, like, what happens if I get aroused and you don't, or vice versa? Is it okay if one of us has orgasm and the other doesn't? What about oral sex? What about manual stimulation and touching? Is that okay? And then what hurts, what doesn't hurt, just sharing about what feels good, what doesn't. What about the use of toys or vibrators and things like that? So these are just some examples of different prompts or different things that might be interesting to talk about that maybe people haven't thought about before. And then improving intimacy. So again, as I mentioned, it's not always about sexual intercourse necessarily being the be-all end-all. There are lots of ways to have satisfying sexual activity for men and women without intercourse. And so talking about things like emotional intimacy, sensual intimacy, and then sexual intimacy perhaps is kind of, a further goal. This top ad where they're in the bathtub separately, it's a Cialis ad, which I always joke and think, if at least they were in the same bathtubs, then maybe that would be, reduce some of the problem. They're in separate bathtubs. Let's get them in the same bathtub. But even something like that, having a bath together, some sensual massage, maybe some dancing and things like that. And again, specialist psychologists are able to do something called sensate focus, and that's an exercise where, and sexual counselors can do this as well, where usually it's several weeks at least, so up to 6 weeks, where you start with each other, just no touching of genitals, no touching of breasts or anything like that, touching, just feeling what feels nice, what doesn't, just gentle caressing and things like that, eventually progressing as the weeks go by to touching different parts of the bodies. And this can sometimes be really important if there's sensitive areas, some scar tissue, maybe from radiation or from surgery, that's maybe really sensitive or painful. But just really getting to know each other's bodies, what feels good and what doesn't. And psychologists or sexual health counselors are trained in this area and can really be helpful in helping couples to go through this. And then improving desire, again, I sometimes think if we can tackle some of the other issues that have been problematic, especially if there's pain or if there's communication issues, if we can fix some of those other problems, sometimes desire will improve as well. It's difficult, we know for sure, androgen deprivation therapy can reduce testosterone to the point where desire can be really impacted adversely as well. Counseling can be helpful, mindfulness-based meditation, again, psychologists can really help with this. And then sometimes, again, the research is coming in this area, but talking about going on a holiday or a trial of intermittent androgen deprivation therapy. So where we're not worried necessarily about, if there's no metastatic disease, so if the cancer hasn't spread to other parts of the body, if the PSA is controlled. Again, it would really depend on the individual risk factors, but talking to the oncologist or the urologist about taking a break from androgen deprivation therapy, and sometimes that can help, again, with improving desire. Improving erectile function, we always want to try to figure out what the reason or most likely reasons are for the erectile problem. So is it a blood flow issue? Is it a nerve issue? Is it a hormone issue? Is it a psychologic issue? It's very often all of the above. But tackling those different etiologic factors can really be helpful. There's so many different things we can do to help with erectile function. Some work better than others, and we've tried most of these in our clinic. I will say the Elator is a device that's custom made. You send away into the States. It's based on length and girth and things like that, where it helps to kind of put the penis into an erect position. It costs about $350 US. It is custom made. We haven't had many patients try this, so I can't really make a firm recommendation about that one way or the other. Most commonly, we would use the medications. So things like sildenafil, vardenafil, tadalafil, so that's Viagra, Levitra, and Cialis. Vanafil, they did not bring to Health Canada. There was an application in 2021, but the drug company withdrew it. The benefit of Vanafil is a very short half-life, and so people could take it in conjunction with having taken something like nitroglycerin. So that's the big no-no with these drugs, is that if you take nitroglycerin within a few hours of taking one of these drugs, it can cause your blood pressure to go way down. And so not a problem if you're taking regular blood pressure medications, but nitroglycerin in particular. Nitroglycerin, which we sometimes use for chest pain and those kinds of things, it can cause very low blood pressure if you take it with one of these medications. These medications all kind of work the same way, so they increase blood flow into the penis, into the tissue of the penis. They all have similar side effect profiles, so there can be things like facial flushing, there can be headaches. Some people will get altered vision transiently. There's PDE5 or PDE receptors for sure. I'm not sure if PDE5, but there's receptors in the eyes as well that can sometimes cause transient vision changes. The biggest difference between the medications is the half-life. So Cialis has got a longer half-life, and that means it will be in the system longer than the other drugs. It doesn't mean that somebody would have an erection or be walking around in the upright position all the time. It just means that potential then, that drug is in the system for longer. So I think always of a patient that was in Edmonton, and he and his wife were so excited to try Viagra, and I'd written this prescription and gave it to him. They got home, they had a nice romantic dinner, and they did some dancing, but then they both fell asleep. And then they woke up the next morning and the drug was out of the system. So Cialis, it would have been a little bit longer. It probably still would have been in the system. There is now a 5 milligram daily dosing of Cialis that allows people to take it every single day. So there's a steady amount of the drug in the system. So with the other medications, you need to take them 30 to 60 minutes before sexual activity. And for some patients I've had, they like the spontaneity. So you take the 5 milligrams every day with all the other meds, and then you've got that drug in the system. So you've got that opportunity for spontaneous activity without having to think, oh my gosh, I got to take it 30 to 60 minutes ahead of time, and plan ahead that way. But really, all of these medications work very similarly. They're not helpful in all cases of erectile challenges. So especially if there's a nerve damage issue, these drugs don't always work. If there's a massive hormone issue, so if testosterone's really, really low, these drugs won't always work. So the other options, again, in our clinic, we taught men how to do the intracavernosal injection therapy. Again, most men, and this would not be first line. So we typically would try other things first, like the medications, the vacuum erection devices. And then if those things weren't working, we would teach men how to do, and sometimes the partners could do it as well, to inject medication into it's usually the sides of the penis, and it causes it causes an erection to happen, usually within about 20 minutes. So we did the first dose usually in the office. We would teach the patient or the partner how to do the injection. It's a tiny, tiny diabetic needle, so very, very, very small. But as I understand, not everyone is keen about injecting into the penis, but it does work quite well. And efficacy is in the neighborhood of 85 to 90%, even if there is nerve damage. So that's where sometimes the medications, if they weren't working, and we tried other things and that wasn't working either, then we would teach the patient in the clinic how to do this. And it can be very, very effective. The transurethral therapy, so things like Muse, the medicated urethral system for erection, where there's a pellet that you place into the urethra, or prostadal cream, which the cream then just gets absorbed into the urethra. Those can be quite effective too, but not as effective. So efficacy is in the neighborhood of 20 to 40%, but that just substance gets absorbed into the penile tissues and causes erection to happen that way. And then the vacuum erection devices can be very, very effective, but you need a good quality device. They can be in the neighborhood of 90 to 100% effective. And how they work is that blood is pumped into the penis, and then usually a constriction ring is placed at the base of the penis to trap the blood in the penis, and they can work quite well. But you do need a good quality device that has a good seal in order to be effective. And then the penile implants, these are surgically placed. So this would be not a first-line option, usually reserved once we've tried other options. They're surgically implanted, and there's different types. So there's three-piece implants where there's a fluid-filled reservoir that's placed in the abdomen, and there's a pump with a release valve in the scrotum and two inflatable cylinders in the penis, and that's the first diagram. And then squeezing the pump transfers the fluid from the reservoir into the cylinders, causing an erection. And then there's another type where there's like a semi-malleable or semi-rigid rod placed in the penis, and then you can bend the rod to create the erection or the desired angle. And so those are, as you can imagine, they're surgically placed. They work very well, 95 to 100% effective, but that's a surgical procedure, so not the first line. Those are something that is fully covered by Alberta Health coverage in Alberta. And ejaculatory changes. So again, we talked about lack of ejaculate. So I think the biggest thing here is just talking about this and making sure that patients and their partners know that this could happen, and that orgasm can still occur even with the loss of ejaculate. And then climacteria, where there's urine leakage at the time of ejaculation or orgasm. And so things to kind of deal with that. So again, making sure the bladder is emptied before sexual activity, trying to avoid caffeine or alcohol or other diuretics before sexual activity, using a constriction ring. I think I have one somewhere in here, but just placing at the base of the penis. And this is what a constriction ring looks like here, the little kind of lasso. There's different types, but this is one type, placed at the base of the penis. And you can see in this diagram here, so it's hard to see, I guess, but this is the urethra right here. And with the constriction ring over top or in place, the urethra gets compressed. So urine has a harder time getting out at time of ejaculation. Using a condom, again, can help trap some of the urine. And then again, pelvic floor physio. So a pelvic floor physiotherapist who specializes in pelvic floor physio can also help to deal with some of these concerns, particularly climacteria. And again, there's very few studies that have been done on orgasmic dysfunction, specifically after prostate cancer. I think, again, figuring out what the issue is there pain? Is there psychological concerns that are happening? What can we do to kind of help with some of those other concerns? Penile vibratory stimulation, or PVS, has been studied to some degree. I think there's still a clinical trial going on in the States looking at this. And then medications, there have been different clinical trials. They have not been very compelling in terms of their results. But things like Flomax or Tamsulosin, cabergoline, and pain medication. So again, different studies have been done, but nothing super compelling right now to say you should take this because that'll help with orgasm. I think with orgasm especially, there can be different reasons why there's problems with orgasm, and if we can find ways to help those other reasons, we can help orgasm improve as well. Okay, testosterone replacement after prostate cancer, very controversial still. There are some urologists in the States that have been studying this for quite a while, and they feel, Dr. Morgenthaler especially, feels that in the right circumstances, this is probably okay to do. But again, it would be an individual case by case. We'd want to make sure that there are not any huge risk factors. So thinking about things like metastatic disease, if the disease is spread. At the same time, if there's advanced disease at end of life and somebody wants to try testosterone to improve function and things like that, I don't think that that would be a contraindication. We think about quality of life at that juncture and trying to make sure that someone is feeling as good as possible. But it used to be that we thought that every little bit of testosterone would potentially increase the risk of prostate cancer cell growth. But if you think about it, as we get older, the risk of prostate cancer gets higher, but testosterone decreases as we get older. So there is some thought now that it's not a linear relationship where a little bit of testosterone, as it gets up, it increases the risk necessarily in a linear fashion, but there's probably some amount where there's maybe a plateau and where maybe things kind of even off. So there might be some contexts where it's not unsafe to have some testosterone replacement. But I would say this is case by case. And as the research evolves, we're learning more and more about this. These are the Canadian guidelines that came out fairly recently, 2021, saying that in men who have symptoms and they've been diagnosed with localized prostate cancer and treated. So they've had localized prostate cancer and it's been treated. And we're watching them and keeping a close eye that there might be a circumstance where it's safe to do a trial of medically supervised testosterone therapy. But again, consulting with the oncologist and or urologist is really strongly recommended. And probably people who have high-risk prostate cancer, we probably would not be giving testosterone to. So I suspect we'll see a lot more about this in the years to come. I'm glad that they are researching it because I think that there are some benefits in terms of not just sexual health, but also bone health and energy levels and things like that too. As I mentioned, penile vibratory stimulation, so it's being studied in the States and in other centers as well. The thought again, if we increase vibration to the penile tissues, if we can potentially improve oxygen and improve blood flow and oxygenation to the penile tissues, and that might help with penile health and erectile function. Studies right now are equivocal, I would say. There's nothing that's really been dramatic. This Vibrec device costs about $430 or so Canadian. You can do the same thing with other vibrators. So you can get, commercially available vibrators, and that would do the same thing. So increasing vibration to the penile tissues potentially could increase blood flow, potentially could increase oxygenation, might feel good too. So there's different types of devices. I would say you don't really need this one in the bottom right. That's a gold plated that retails for $17,000 US. You don't need anything like that. But there are different devices, some that you can use with a partner, some you can use on your own. The Gyberator, I have one here that you can come look at after if you like. These, by the way, have never been used on anybody. These are all like demos and things. So just to put that out there. But the Gyberator is one that's been designed for men, and it is intended to be used. It can be used with a flaccid or semi-erect penis. It doesn't require full erection, and that vibration and that stimulation can sometimes be enough to lead to orgasm. So there's different devices and things like that. So again, to keep an open mind and not to do anything that's outside your comfort zone, but just to realize that there's different things that can sometimes help. And then again, just to speak quickly about safer sex. So there's not been any great studies to look at these things, but we do caution people when their platelets, those are blood clotting cells, when the platelets are lower than 50, to just be careful about rough intercourse or anal intercourse. And the same thing when the neutrophil count, that's the infection fighters, when the neutrophil count is very, very low. It's the same thing. We don't like people to have rectal exams when the neutrophil counts are low, so we would caution people to not engage in anal intercourse or, again, really vigorous sexual activity when the blood counts are low. But that usually for most people is such a short amount of time. So I remember working in stem cell transplant, and I talked to one couple and they said, well, we haven't had sexual activity of any kind in more than a year because we didn't know if it was safe. And I thought, oh my gosh, they wouldn't even kiss or anything because they just didn't know if it was safe. And I thought, we have done such a disservice. We should have been telling them up front, it's okay to do X, Y, and Z. And when the counts are low, maybe avoid these things. But never should things be completely 100% off the table. I think there's always ways we can modify activity to make sure it's the safest as possible. With chemo and different treatments, we know that the majority of those medications are out of someone's system within a few days of receiving them. It's more difficult when people take daily chemo because then there's probably a little bit that's still in their system and potentially in their vaginal or penile or semen secretions and things. The chance of that kind of, if there's a little bit of residual chemo that makes its way into the semen, and the impact on a partner, then we don't really know what that would be, but the risk would be very, very low. We can't ever say it's zero, but the risk would be very, very low. There have been anecdotal reports where some people have said that they can feel a stinging sensation after having sex with someone who's receiving chemo. But again, the amount of chemo that would get into bodily secretions that way would be very low. If you're worried at all, using condoms, female condoms or male condoms, dental dams and things like that can reduce the potential exposure. But again, that risk would be quite low. So just to kind of summarize and say, we're not talking only about sexual function, sexual intercourse, but intimacy. So physical intimacy, emotional intimacy. There doesn't need to be an erection in order to have orgasm. There doesn't need to be ejaculation in order to have orgasm. There can be very satisfying, fulfilling, meaningful, pleasurable sexual activity and physical activity in the absence of erection, in the absence of sexual intercourse. Sometimes it's a reframing of sexual practices and thinking about different things, different positions, different approaches that might feel better. Making sure that medication use is timed appropriately. So we're doing pain medications in advance or those PDE5 inhibitors in advance, and just really trying to find what works best for each couple and each person. So I would say it's very common for changes in sexual function and sexuality to occur after a diagnosis of really any type of cancer for both the patient and the partner. There's so many different ways that we can help to make things better. If something's not working, we can try something else, and we can, modify things and add different things in or try something else. There really is no right amount of desire, no perfect relationship, and no normal sex life. Those are all myths, I would say, for sure. and talk to your healthcare provider. If that person is not comfortable talking about sexual health, refer them to me. I'm happy to answer emails or phone calls about questions if the provider is not comfortable. Again, as I said, if something isn't working, don't give up. Try something else. There's lots of different strategies, and keep talking to each other, to your healthcare provider, and don't give up. There's lots of good websites. I always tell people, use these specific addresses. Don't just type sex into a Google search, because you end up with some interesting things, as I've come to realize. And yeah, my AHS computer, whenever it'll get audited, I'm sure they'll be thinking, what have you been up to? But and the prostate cancer, Prostate Calgary, PCCN Calgary, Prostate Cancer Canada, all have great resources. There's wonderful books as well. I have all of these. I usually bring them, but I didn't today. I'm sorry about that, but they're all wonderful, these books, and some LGBTQ specific resources as well. And I think I've rambled on for a long time, I'm sorry, but happy to take any questions, and I'll just maybe pop my email address back up there again. Then if people want to email me, and even for people online, and I know after the previous the previous talks I've given, I've received emails from people in the States and all over the world, so please feel free to email, and I'll try to answer any questions that you might have or direct you to resources that you might find helpful. And happy to take questions here as well.
Thank you, Reanne, for sharing your knowledge on a topic that everybody wants to hear about, but nobody wants to talk about.
That would be the name of a good book, I think, yes.
Yeah. So thank you so much.
You're
we
very
appreciate
welcome.
you.
Thank you so much.